Good evening, everyone. I hope you are well, and thank you for joining us again. I am Dr. Jeffrey Sterling. I am Surgeon General of Alpha Phi Alpha Fraternity Incorporated. And on behalf of our General President, Brother Dr. Willis Lanza III, and our Board of Directors, I want to welcome you to this very special edition of the Surgeon General Initiative. This evening actually marks, I guess I'll take a point of personal privilege here. This evening marks my 42nd anniversary, and I couldn't think of a better way to join it than to conduct a session which I will be moderating with three of my line brothers who also happen to be physicians. I will be introducing them, and this evening, the topic is something that everyone who's watching this should actually feel, whether or not you deal with it in your face or whether or not you are subject to implicit bias. We're going to be talking about a variety of things that fit into the category of social determinants of health. We're going to be talking about access to healthcare. We're going to be talking about navigating the healthcare system. We're going to be talking about accessing quality of care. And we have multiple specialists covering different parts of medicine who will be engaged in this conversation. And again, allow me to welcome and wish a happy 42nd Alphaversary to three of my line brothers. Let's start with Brother Dr. Glendon Barres. Brother Dr. Barres is a pediatric gastroenterologist. He literally was the first Black PGI physician trained at the University of Chicago, which at the time was the leading pediatric liver transplant program in the country. Dr. Barres has served as clinical professor of pediatrics at the University of Illinois College of Medicine for the past 28 years, where he has won numerous teaching and mentoring awards. Dr. Barres has also served as chairman of the pediatric department at Swedish American Health System in Rockford, Illinois for 7 years, and he currently practices at Hoffman Estates, serving a diverse patient population. Welcome, Brother Dr. Barres.
Thank you.
Also part of SS 10 Karat Gold, Northwestern University Alpha Mu chapter. Next up, Brother Dr. Wayne Alonzo Ford, who is a board-certified family physician and healthcare advocate for vulnerable populations living in under-resourced communities. Brother Dr. Ford completed medical school and residency in family medicine at the State University of New York at Buffalo. He has worked as a full-time physician at a federally qualified community health center in Buffalo, New York, and clinical faculty at the University of Michigan in Ann Arbor. Currently, Dr. Ford is the assistant professor at Case Western Reserve University School of Medicine in the Department of Family Medicine, where he has practiced a robust effort of over 25 years. Brother Ford is also Chief Medical Officer for Asia's International Community Health Center with offices in Cleveland and Akron. And most notably, Brother Dr. Ford is currently serving as the president of the Ohio Academy of Family Physicians, representing over 5,000 family physicians in the state of Ohio. Welcome, Brother Dr. Ford. 10K. All right. Next up, we have Brother Dr. Kevin Smith, who is an associate dean for academic programs. Excuse me, he is the associate dean for academic programs and affiliations at the Morehouse School of Medicine, where he is a distinguished leader in obstetrics and gynecology. With a foundation laid during his residency and fellowship training at Stanford University Medical Center, Dr. Smith has notably pioneered transformative initiatives. As director of gynecology and reproductive health for the West Oakland Health Center, for example, he forged a partnership revolutionizing access to care through telehealth wraparound services for underinsured pregnant patients. Under his stewardship as chairman of OB-GYN at the Alameda Health System, the department initiated groundbreaking programs addressing healthcare disparities, including the Women's Reproductive Health Equity Fellowship and the Black Centering Prenatal Care Program. Dr. Smith's commitment to racial equity extends to Howard University Hospital, where he secured grants and conducted research on conditions disproportionately affecting Black patients, notably endometriosis and fibroids. His academic journey includes completion of the Harvard T.C. Chan School of Public Health, Go Crimson, for chairs of clinical services and the California Healthcare Foundation Leadership Fellowship. He has been, of course you have, been recognized as a super doc, and Dr. Smith impacts resonates across academia and healthcare, shaping a more equitable future. And notably, last but not least, you were captain of our line, so that counts for something.
Oh, six.
Before we get started, we have to give a shout out to Brother Dr. Gregory Coleman, who couldn't be with us this evening, but we all, as well as the rest of the 10 of us in 10 Karat Gold, Let's just go out a healthy, happy anniversary to our team as we get started. All right,
Happy
and
anniversary.
so we have PGI in the house, we have gynae oncology, we have family medicine, and of course, I'm coming to this through the prism of emergency medicine. So let's actually start with there, because part of this conversation is about how we suffer through, as a community, how we suffer through healthcare disparities. Everything is more difficult for us, meaning access to care, access to quality of care, having to absorb higher cost. And one of the things that translates into is, if you looked at the top 10 causes of death in the United States, we literally are disproportionately affected by 9 of those 10. And unfortunately, what I've seen in my career as an emergency physician is that the emergency department is used as the portal of entry for so many members of our community. It's just a horrible situation. And what we want to talk today is about how this is not even a class-specific phenomenon. Communities of color have to deal with the ramifications of these inequities and disparities, regardless of our levels of education, and to a lesser extent, regardless of our income levels. So what I actually want to start with is, what does it mean, boots on the ground? Each of you have had your own clinical practices. Can you just talk in very general terms about what it has meant to have to deal with patients that have difficulty navigating the healthcare system? And as our resident president of the Ohio Academy of Family Physicians, let's start with you, Dr. Ford.
Oh, thanks, Jeff. So, I mean, I really start off with healthcare does not equate to health. I mean, health is really determined in a lot of instances by what you said before, the social determinants of health. And as far as your boots on the ground, it's me dealing with those particular issues. The social determinants of health is really where we should be looking when we're talking about the health inequities that we see in our community. And it's a difficult problem, and it's hard to define in a way. But again, it's me interacting with those social determinants of health and trying to find those out on my patients, as well as trying to alleviate some of those. That's a kind of one-on-one with patients. But then looking on policy-wise, we can get into that a little later. But on a more personal note, that's what I'm dealing with. And again, some of the opportunities that I have run across, especially with with electronic medical records, we're able to do more in the way of assessment of these social determinants for patients, and then trying to make linkages to try to help them overcome those types of problems.
Let me stay with you for just a second, because I actually want you to expound on that for the audience. Let's talk about the social determinants of health very briefly, because it's kind of hard when we put patients in financial situations that require them to choose between food on the table and having to pay for their medicines, asking individuals to speak different languages, to read instructions that aren't printed in their native languages. Can you just actually tease out a little bit more for the audience what we mean when we talk about various social determinants of health?
Yeah, so the social determinants of health is, I guess I'd use the World Health Organization definition, which would be more of where people are born, where they live, where they work, where they age, what kind of the things that they go around, that are around them during those time periods. And again, so we're talking about, like you're saying, food, shelter, having
Environmental education.
all that would be part of the social determinants.
Yeah, so basically, as you started off with, where you live can greatly affect your health. As some people may remember from various movies, if you live near certain electrical lines, that increases your risk for cancer. There's so many examples of how the environment in which you live predisposes you and increases your risk for certain types of disease. And the relevance in bringing that up is that our communities are the ones that far too often are disproportionately affected by those phenomenon. So, one of the things that's fascinating about this is that even as a primary care physician, people have difficulties accessing the system. And as I mentioned, they end up far too often in emergency departments as their port of entry into the healthcare system. So if that's a problem, imagine, if you will, the type of difficulties that exist when you're trying to get specialty care. So let's bring brothers Dr. Smith and Barres on the back up. Thank you very much. And talk about how difficult it is for people to access you. It's just amazing trying to get referrals, because you guys, I would bet, over the course of your career have never been double booked every single day over the course of a day. So why don't you go jump in and comment? You muted.
You're muted.
Sorry about that. Being a pediatric gastroenterologist, there's only so many of us around. So, to get to me, you have to be referred. There's a limited number of us. There's limited time. Our schedules are booked, and we tend to not be right there, in the community. We may be at a major, university center or somewhere else. So just trying to get to us can be an issue. So the booking is scheduled out so long. Our pediatric neurologists, I hear the MAs calling the homes beforehand, telling them, listen, if you miss your appointment, you won't be seen until next year. It gets to that point. And so when you talk about all the obstacles that go into, there aren't many of us, we're booked. If you're 15 minutes late, you won't get in. And that's just to see us. And then once you see us, we have the obstacles as far as being able to explain in detail that you can understand your diagnosis and convey it to your child and convey it to your primary care physician. There's a lot of obstacles that go into seeing me, and I try to keep that in mind, each time I see patients. But there just aren't many of us. We're spread out very far, and getting to us can be an issue.
Yeah, but boots on the ground. I'm using the phrase boots on the ground, but what about the people that don't have boots? What about the people that don't have cars? What about the people that don't have insurance? That just is a force multiplier in terms of increasing the disparities, because it's hard to get at you under normal circumstances. How do you even deal with the notion of people who aren't coming to you through a direct referral as an insured patient? How can those people possibly hope to get a hold of you, given that you're already scarce?
Well, a lot of that I tell you, to be honest with you, most of us are, especially in pediatrics and specialists, most of us are employees. It's hard to do this on your own out on the street, just with your own clinical practice. So a lot of it comes down to your healthcare system and how they're helping patients get in to see you easier. Other than that, you try to get them in whenever you can. I can get into later some of the situations I've been in where healthcare systems have told me, listen, your patients who are on Medicaid, they tend to be late, they tend to no-show. So we're going to limit how many of them you can see. And it took me going to administration as a department chair saying, hey, that doesn't work. Those people used to be me, and I'm going to see them. And you're not going to tell me I can only see 5 a month. So, it takes some pushback, but as an employee of a health system, that can be difficult.
Yeah, I'm going to come back to that last point you made, because the power that you've had as a department chair is part of what the solution to these things need to be and what the audience needs to be aware of in terms of trying to navigate these things. Kevin, brother Dr. Smith, you've had an amazing career. You've been on the East Coast, Howard, moving over to Meharry, over to Oakland at a county hospital in private practice. You've seen this from multiple different avenues. What would you comment? What would you add to the conversation that the other brothers are putting forth?
Well, I respect and admire Meharry, but I just want to be clear that this is the Morehouse School of Medicine.
Thank you.
Yeah, you got the Howard correct, but who knows? It could be next. I just think it's multifactorial. I think there are a couple of intersecting challenges. Number one is the social determinants that both my line brothers here have talked about. And then there's this resource scarcity. So as Dr. Barres talked about, in general, doctors are aging. There are less doctors around. If you talk about OBGYN specifically, we are anticipating fewer and fewer obstetricians to be available by 2030 than we even have now. There's 50,000 reported obstetricians in 2018 in the country. For everybody. And then we have to talk about what kind of practitioner do you want your Black patients to see? We want cultural and racial competency, concordance, and that's an entire different effort. So I think things like federally qualified healthcare centers that Dr. Ford has been at, that I've been at, probably the two of you have been at, do focus on patient centricity and really make an effort to address those social determinants of health as a practice, as a medical practice.
That's fascinating. I'm going to stay with you, um, Dr. Smith. I just want each of you, I think Dr. Barres touched on this. I want you each to get on it because one of the beautiful things about having you three on here is that you each have had very significant administrative roles. And part of what we do in these conversations is not just to highlight the problems, but to identify solutions so that even though the solutions aren't optimal, they empower individuals to know how to try to work the system. So in each of your varying capacities, why don't you try to discuss the type of advice that you give to people who may not have optimal access to the system? Because, I'll start by just saying too many times people are coming in through the emergency department and requiring us to get them a golden ticket in to see specialists, and even in many instances, a primary care physician. But let me turn it back over to you, and I'll start with you here, Kevin. What do you think you can offer as an administrator? How can you change the system? How have you changed the system to help people out?
So I think the access piece is, it needs to be addressed from a patient focus. So many times patients are getting to the emergency room not just because it feels like.
Got to freeze.
Oh, did I freeze?
Technical.
Am I
I'm
freezing?
seeing you. I'm seeing
No,
you.
you're good.
Okay.
You're good. Keep going.
So I guess I'll shorten the answer in case I do freeze. There are options to provide that access and kind of disimpact other clinical settings like the emergency room, like telemedicine. And we saw how that really became important and the only option during the COVID crisis or pandemic. But that really helps with providing access to patients, and it's very patient-centric. And I can't imagine a system that cannot support that right now and stave off these emergency visits that you're talking about.
Yeah. Brother Ford?
So again, I'm going to try to push forward. You need a primary care physician. You need someone who would be that quarterback directing care. Again, so it's a matter of trying to. I know there's a shortage there also, but it's a matter of trying to act. Kind of use that as your entree into the care. It's been shown that if you have a family physician, the places that have the most family physicians have better access as well as better care ultimately. Again, on the policy front, trying to go forward, and things that I do is, again, advocating for more of those social services and mental health services that that communities need to again, we talk about this, to combat the social determinants. I think that's one of the things that we need to push forth.
Yeah, I think that deserves a reiteration, because I think that a lot of people don't especially realize the importance of having a medical home and a family practice or practitioner who literally is that quarterback who will act on your behalf to navigate through the system. So that is so much of the work that's done in emergency departments. You may need PGI or gyne-onc, but your care is not going to be best accomplished by episodically bouncing around in varying emergency departments, regardless of how good the physicians are that you're dealing with in real time. So much of our efforts at the same time that we're trying to get you to specialists actually involves making sure that you have that family practice or internal medicine quarterback to make sure that your care is being coordinated and that follow-up is being done as it is supposed to. You want to jump back in on that, Brother Barres?
Yeah, I would. As a specialist, I like walking in the room and seeing somebody who looks like me, because, as we all, we're brothers, we all remember where we came from. So I go out of my way to let them know, hey, listen, you can't be late next time. I saw you today and you can't be late next time because they'll turn you away. And I feel comfortable being myself with the patients because I'm the endpoint. You know, you had to get referred to me by an ER in your primary care, and now you're here in front of me. So here's how we're going to do things. You know, you got to communicate with me when you're having issues. Everybody in my office will be nice and kind to you and explain things, but you have to show up on time. If you need help with transportation, we can help you. You need a meal voucher, we got that for you too. So, you know, now that you're here, you know, this will be your home. Because what I'm finding is not everybody has a medical home, and especially when I in my past life where I worked before, you know, yeah, we had a lot of, you know, public health centers that were in the community, but the turnover was ridiculous. You know, I've done a lot of my work with the school system in Rockford, Illinois, getting children prepared for school, getting children prepared, and a lot of the school system issues are very similar to the healthcare system issues, you know, as far as facilities, as far as turnover. And so many of these patients don't feel like they have a medical home. They have a new doctor every year or two, somebody who's just working there as an obligation. And so many of them depend on me to help them with the most basic of needs. And so, you know, I try to do that because I understand some of the limitations they're having back home. And like Dr. Smith said, you know, I try to do as many virtual visits as I can. You know, I see you're having trouble coming to see me. You know what? Next time, let's do it virtual. You see that screen on the wall? You'll be right there. We'll talk about all the same issues, and we'll get all your issues addressed. So that's a big deal right now. Getting patients seen virtually can get them access to places they couldn't get access before.
Thank you. And that's a great segue to where I want to go with this next. And I think that at least two of you have already touched on this. I want to talk about opportunities that exist, innovations that are in place by which patients can obtain greater access to the system. Actually, we'll talk about three, but I just want your advice. Glenn, you actually just spoke about this, so I'll talk this one back over to Dr. Ford. Can you talk about what the role is for telehealth and telemedicine in actually increasing access and helping patients navigate through the healthcare system?
So again, I guess this really came up with the pandemic. I mean, as far as learned a great deal on the virtual visits and telehealth visits, and we're still learning about those. But again, it's been shown that for the particular problem or for certain problems, the telehealth or virtual visits can be just as effective as far as, again, the entree to care and getting things, getting people in, having that, you know, maybe even expanding my reach and my ability to see patients in that. So again, I think telehealth is here, and telehealth is here. Telehealth and virtual visits are here to stay. And I think as time goes on, we'll learn more and more about it and make them better in that instance. And I think that's another, again, what was said earlier, another entree into the healthcare field.
Dr. Smith?
I'm having two thoughts. One is, first of all, I think my line brothers are just brilliant. So three thoughts. You guys are awesome. The next one is the workforce, which is, and I'm having that obviously because of this new role I'm in. How do we create the pool of providers of color? And that's part of the big effort we're on now. How do we get more into medical school? Where does that pipeline start? And then how do we make people successful there, and then have them actually be incentivized to return to those communities where there's less access to us to provide that concordant care. And then I was also having this wild thought about AI and where that might ultimately go in here. And I was at a conference not too long ago, and they talked about the utility of AI in diagnoses, and maybe replacing you, Jeff, in the emergency room, and putting these these algorithms in, which is scary, right? Because we already know that we have problems with AI even identifying a Black woman's face, like distinguishing that from anybody else. So lots of thoughts popping in my head about how we can address this, but we need to obviously increase the pool of providers who can even treat patients, or provider extenders, mid-level providers, et cetera. But I am hearing discussions around AI.
Indeed. You actually are, you all are doing a great job, obviously, and doing a great job segueing into the next thing I want to discuss. I do want to talk about, let me just give a little bit of background here first. It was interesting at the point in time in which the Affordable Care Act was implemented. People don't really talk about this much in public health circles as much as I would believe that they should. But the idea by President Obama and his team was to reduce the uninsured roster by some 30 million individuals. There used to be 50 million uninsured, and the target was 30 million. And out of all the, excuse me, out of all the innovations that were rolled into the Affordable Care Act, one thing that was notably not present was an increase in the physician work pool. And as luck would have it, or as design would have it, there was literally an army of 170,000 nurse practitioners standing on the side waiting to get in on healthcare. And one of the things that occurred concomitantly with implementation of the ACA was a introduction to nurse practitioners. As we said, I'm actually in New Mexico, where this community is receiving its care overwhelmingly through the efforts of nurse practitioners, so much so that when you ask them who their physician is, that is how they will respond. And it's just a fascinating consideration. So I'm throwing that out there because, again, getting back to the cultural sensitivity and specificity that results in better healthcare outcomes, I'd actually like for you all to comment on what you have seen over the last 10 to 20 years in terms of adding what used to be and still is called mid-level providers or advanced practice nurses, and whatever the case may be in terms of labels. How do you think they appropriately have fit into deliverance of care, augmenting the efforts to avoid healthcare disparities, et cetera? Let's have you jump in. Let's start with you again, Dr. Ford, from a policy standpoint.
So sorry. So again, I guess as far as nurse practitioners and physician extenders, I think there's a place for them. What we kind of run into is the differential in education and experience that the nurse practitioners will have, and independent practice kinds of issues that they come up with. So again, I think there's a place for it. I think that physicians are again having physicians as their back kind of supervisory types of approaches is probably where I would be coming to this from. And again, I've worked with in all my practices, we'll have a kind of extenders, nurse practitioners, and I supervise a number of them in my practice at the county hospital, as well as at the community health centers in which I've worked. So again, I think it's part of the answer, but again, it's something we have to learn from, as well as make sure that the community and patients understand that some of the differences that are offered in these particular settings.
I'm going to stay with you for a second on that question, because on behalf of the American Academy of Family Practitioners, I think this is an issue that doesn't get as much discussion as it probably needs. The growth of nurse practitioners in particular has actually been driven even more than the need for their services in communities, or the utility that they bring in the ways in which you described they will be best used. Their growth has been largely driven by lobbying considerations. I don't think that physicians would have necessarily, based on what you said in terms of the disparities in training and experience, would have set them up as independent licensed practitioners, just to give you one example, but that indeed is what exists. Our physicians, and there was just a wonderful paper that came out just last week from the American Medical Association, if I remember correctly, actually looking back at healthcare outcomes that were being delivered by these independent licensed practitioners, and it wasn't a very complimentary review. So what are physician organizations doing on behalf of patients and communities to ensure that these physician extenders are being used appropriately and in supportive ways, much akin to how gatekeepers are being used, as opposed to setting them up where they are the primary caregivers in communities, if you feel like that's not the most appropriate and best utilization of them?
So again, as far as the American Academy of Family Physicians, we really do want to educate the public and make sure that it's kind of state by state. It's almost like state by state rules as far as independent practice of for the nurse practitioners in that. So again, it's kind of a state by state battle, and the education that needs to go along with that, so that they know that the education that I have or we have as far as physicians versus nurse practitioners. I think it was originally set up that it would be people who have been years in nursing and then move on to advanced degrees in nursing to supply care. Now it's something that just kind of goes through almost like a graduate, like a master's degree straight out of college, which again limits their exposure. Again, that gets into what we need to do as far as educating the populace. I'm not totally against it. I think it needs to be it needs to be in a system where it is monitored, and from the standpoint of primary care, I think they can offer primary care, but often nurse practitioners are trying to move into the specialty fields, which pay more and maybe have a little more prestige, better hours, those types of things. And again, that's something that needs to be watched.
Okay. And again, that's an important conversation to have in the context of tonight's topic, because the comments that are being made here are not anti physician extenders by any stretch. It's really pro-patient. And Dr. Smith, what's the danger in allowing individuals that don't go through the rigorous specialty training that you and Dr. Barres, for example, have gone through? Because a hospital administrator, I deal with this literally all the time. The difference between, just to give you one example, a nurse anesthetist and a anesthesiologist is so great that an administrator simply can hire multiple nurse anesthetists and then have a physician who's medical director, and voila, I've just saved tons and tons of money. But to the extent to which that poses a danger, if the data bears that out, of course, what is it that we can do, and what you've done as a department chair in an OB department, to make sure that you're holding the line on quality of care as job one, protecting patients' interest?
I have the answer that I want to offer, but I also want to lay a foundation a little bit differently than what's been said so far. Particularly in obstetrics and gynecology, where, as I described to you, there is a shortage. And I think no one has not heard about the higher risk of mortality from obstetric care in America versus any other developing country. And obviously that is worse with Black patients. But the point is that because we needed to have more care in California, not only have APPs, as you would call them, been more utilized, but the laws have changed such that they really need less and less supervision from a physician. And that's to support, for instance, rural communities where you need this medical care and there are no doctors there. To answer your question specifically, the same peer review process that I would employ for my physicians, we have for the nurse practitioners and midwives who are also APPs in that setting. I think that they can be quite talented, quite good at what they're doing clinically, and quite effective for this question we're having around access.
So as Brother Dr. Ford said, there's a role, but that role needs to be really looked at, because I'm here to tell you the lobby effect is equally as impactful on this conversation as any qualifications or data-driven analysis of equivalence of care. And I'm not going to let you get off the hook without pointing out, you did point to it, but I think it bears repeating, that Black women have a almost 3 times, I think it's 2.9% increased mortality rate than members of the general population. So in that setting where we're already, even under the normal circumstances, receiving, you have to just call it inferior care, because it's resulting in such so much worse healthcare outcomes, then it becomes problematic if you are allowing our community to be the community that actually has to deal with with all due respect, a lesser trained quality of provider. Dr. Burress, I know you want to jump in on that.
Go ahead, Kevin. Go ahead, Kevin. Go ahead, Captain. Let the captain go.
Whoa. So let me just answer that directly. Jeff, you mentioned when you introduced me that I was instrumental in helping to develop Beloved Birth Black Centering at the Alameda Health System. It is a midwifery-run Black centering pregnancy program, and our initial data was so much better than conventional obstetric care in terms of the preterm birth rates and the low birth weight rates, which were, 1 and 2 killers of the newborns. That it argues against your general premise. But what we did was we created a racially concordant Black centric model. It was Black midwives, it's Black medical assistants, it's Black high risk OB docs that you would see if you needed to. It's Black. So it just changed the gauge. And so I just don't, I don't think that necessarily the training, the type of provider it is the issue. It's the type of care that's delivered.
Well, let me jump in on that before I give it to Dr. Burress, because there's an important point to be made here. Let's make sure we're controlling for the correct variable. No care is obviously the least desirable option. Excellent care by excellently trained clinicians at the highest level would be the gold standard in between. I think that the data, the public health data, has always been clear that better healthcare outcomes in the Black community are best produced when they're being delivered by culturally sensitive and culturally specific providers of that care. And within that dynamic, the data is again clear that you, like you said, you set it up. So I've put paramedics to be intubators in a trauma center in Milwaukee. I've used nurse practitioners and physician assistants to accommodation in a level 1 trauma center in Houston, Texas. So you're absolutely right. And thanks for the opportunity to clarify that. Physician extenders can be used quite well to produce excellent healthcare outcomes in the right settings, but that runs counter to the notion that there is an equivalence of either education or training until and unless a level of experience and an ongoing ability to supervise and to work with them as colleagues and bring them up to snuff to where they can produce that level of excellence that they can actually represent. And I think that gets back to the point that Brother Wayne was saying, yeah, let's add them to the force, but let's be careful about how we implement those strategies. I'm sorry, Dr. Burress, jump on in.
Yeah, I think the big issue is it's not just access to healthcare. To me, it's access to beneficial outcomes. We can put some bodies in a place just to say, okay, there's some people here, there's some physician extenders, there's somebody you could see, but is it somebody who's going to get you the outcome that you need? I've seen excellent nurse practitioners, I've seen bad ones. I've seen excellent physicians, I've seen bad ones. And I know from the patient you send to me, I get patients who had very little thought put into their care. And the care may be even the opposite of what is needed. And I'm happy that this physician or nurse practitioner sent them to me so I can straighten this all out. So like I said, it's an access to a beneficial outcome. So when I'm the endpoint and you're coming to me, that's all I care about. I'm not really caring who sent you to me. I just want to make sure they didn't harm you before you got here. And how can I get you fixed? It's the outcomes that are important.
Well, it's kind of like how I started, Jeff, was that healthcare. So access isn't the only variable. I mean, right. Healthcare doesn't equate to health, and health can be defined several different ways. But healthcare, having access, isn't the end all and be all of what you're describing. So from that standpoint, it's a complicated situation, and because it's a complicated situation, you do need the big data to show that that the blacks are definitely dying at a younger age, and then you start looking at why, and the why is we talk about social determinants, the things that that the inequities that have come down through the ages.
What a wonderful set of points you two have made, but I'm actually going to push back on both of you because I'm boots on the ground in a very organic way. Access to care isn't everything, but without access, you don't even get care. Okay, so here's the point. Dr. Barres, you have, as brilliant as you are, you can't even possibly fathom just how on point that comment was. And I know that's saying a lot because, we have over the years seen nurse lines. We've over the years seen, and now we're seeing all the way up to telehealth and telemedicine. That is the design of the system. And let me just say this on behalf of emergency medicine. Emergency medicine is the youngest healthcare specialty. There still are only enough residency trained emergency physicians to staff about 40% of the hospitals in the United States. So this idea of access to care in emergency departments isn't what you think either. And what I'm getting at with this is that so much of the game of navigating the system is to just get into the system because you are the final common denominator. You represent the clinically excellent care that represents healthcare outcomes. So much of what occurs in rural America, where there may not even be a physician and there may be a regional doc who's on telehealth, for example, such as a community where I am right now, and so many other places that don't have experts like the three of you available to them. The name of the game is literally just getting them into the system, somehow helping them navigate the system so that they can finally get to the specialist or to someone who can actually provide them with a level of care that reflects best practices and results in healthcare outcomes. And I know, especially for you guys that are specialists, you're so far removed from that. If you're in a academic healthcare center, you're so used to operating at the peak of your profession. So let me tell you, as a guy who's been a grunt, who's worked in community hospitals in dozens of different states, as you know, I've been a medical director at 25 different places and a department chair at 3 level 1 trauma centers. It is not always clinically excellent care, but without that access, nothing else even happens. And that is too often what we began the conversation with, going back full circle, as Brother Ford said. The social determinants of health stack the deck against so many who are indigent, who have certain skin colors, and who have other inabilities to access the care in the optimal care. I know none of you are suggesting that, but this is a very complicated topic why we wanted to discuss it. The last thing I actually want to pivot to is just for you to really just talk to the audience and talk to some of the brothers in particular regarding how they can take care of their families, how they can do what needs to be done to provide better care for themselves and better healthcare outcomes for their families. And again, as always, we'll start with our gatekeeper, Brother Dr. Ford. Why don't you go ahead and start as our reigning king of family medicine?
Reigning king. Okay. Yes. I think I've mentioned this before, and I think it is like you start. Like, I do agree with you, Jeff, as far as access. It starts at access in a way. But again, in my experience, I'm kind of working beyond that in a way, meaning that once person gets to me, I'm trying to get them the appropriate care. So having, kind of trying to find a primary care physician, hopefully one of color, or racially or ethnically concordant, I should say that more, is probably where I would start if that's possible. Again, I know that there are more hurdles there than I care to count in all of that. The aging of the physicians available. So we have to bring more in the pathways. Those types of things are something to pay attention to. So, like I said, I guess I would be saying, have a primary care physician, if possible, a family physician.
So hard stop there, folks. No matter what you think, you will get qualitatively better care if you go out of your way to establish a relationship with a primary care physician. Let's go to Brother Dr. Smith. What do you got, Kevin?
Yeah, I agree with Brother Wayne, His Highness, His Royal Highness. But one of the things I like to tell everybody is a second opinion. Always be comfortable getting a second opinion, even if it's from me. If I'm your doctor and I'm giving you advice, it's okay. I think second opinions are empowering, and you're entitled, and they may change your level of understanding of your options. So if your question was, what do we advise the brothers listening to support their families' second opinions and third opinions? I like the idea of having someone with you when you're in the exam room, having someone taking notes, or in the visit. They may not allow you in the exam room necessarily, but in the visit, having a second pair of ears and eyes and hands when you're stressed out about what this workup is, someone else can be objective and someone else can ask questions. Providers and doctors can be intimidating, not even intentionally, but sometimes intentionally, and you need someone there to help offset that. I think, we know that there's not as many Black physicians out there, but I like how Wayne kind of corrected for cultural humility, cultural competency. If you don't feel that it's, one of my patients told me once, and I want to get a t-shirt, she said, if it ain't right, it's wrong. And I love that, because it's simple and so profound at the same time. And if it doesn't feel right, it's not. So that would be my advice, and to feel empowered around questioning that.
Fantastic. Brother Dr. Barres?
Oh man, it's been, first of all, it's been great being on a panel with these distinguished gentlemen. Oh my God. I mean, I have a few thoughts on it, especially, I come at everything from a pediatric point of view. I figure it's my job to keep people out of your offices, out of your ER, to keep them healthy. So, one of the things I initiated in Rockford, I was chairman of a group, it was a 0 to 3 program, just getting kids ready for school. So you ask, what can people do at home to better their health care and better their families? Get your child ready. It was a program called Talk to Me, and it was really just about talking to your child from day one. You watching the Bears game, you say, hey, why did they run the ball on 4th and 6? You're talking to your 6-month-old, but it's still developing language and skills, communication that are important. Another thing is, we had a nice obesity program, which is, let's face it, most of the people in the hospital that you're seeing, it has something to do with obesity, whether it's diabetes or heart disease and strokes and everything else. So nutrition is so important. So I would like our audience to focus more on their nutrition. I don't think as a gastroenterologist, I understand it. I don't know if everyone else understands how important that is to their overall health. So all the people out there who have a family, who have young ones in your family, focus on their nutrition early. Oh my, if I had $1 for every kid who eats Takis every day, I would be rich, but to me, that's a reflection of the parents. Then the other thing I would say is ask for help. So many of us get in a certain surrounding and situation where we're overwhelmed. We don't understand what they're talking about. The squeaky wheel gets the oil. So you go to the doctor and you don't understand what they're saying, ask them what they're saying. I saw something on social media the other day. It was from a Black medical student, and he was doing rounds, and they were telling a Black patient that he had MS. And they just basically said, you don't have a brain tumor, you have MS. And he didn't have any questions. And after rounds, the non-Black faculty were saying, he's so apathetic. I can't believe that guy. And the Black medical student went back to the guy's room to speak to him. And that's when he answered questions and he taught the patient. He did the things that it takes for that patient to understand his illness. So I just think people need to speak up, ask questions, take control of your health care, and you'd be surprised how far that'll take you. And take care of your children.
Can I just throw in one more thing here, and probably brother Ford knows even better. There's some screening things that just have to happen for Black men. So I want to make sure that we talk about prostate screening, we talk about colorectal cancer screening. Just go get it done. I can't stress that one
Stop smoking.
strong enough. Yeah.
Stop smoking. Yeah, fix your obesity.
Well, brothers, it's been an absolute pleasure to be with you. Love you all. Thank you. We will do this again on a different topic down the road. Actually, in my closing comments tonight, I'm going to pull an audible. I've backed 1 million communications during this talk, and I'm going to start this by just picking up something that Dr. Ford put down. Healthcare indeed is not health. As a matter of fact, healthcare these days is actually medical care, and medical care is not healthcare. Healthcare is healthcare. What I would actually like to impress upon you is that you had better become a better steward of your own healthcare. You need to stay ready so that you don't have to get ready. An ounce of prevention is always worth a pound of cure. If you want to produce better healthcare outcomes for you and your family, you need to avoid entering the medical system as much as you need to be able to navigate the medical system when that time comes. Diet, as I think it was Dr. Barres, obviously, as a gastroenterologist, and Dr. Smith were just pointing out, diet is 80% of the conversation when it comes to health. Everything else that you do in terms of medical care and exercise is meant to clean up some of the stuff that we put into our bodies. We are incredibly resilient. We can be great. But please continue to enjoy these webinars because they are meant to empower you and point you toward the way of doing better for yourself so that you don't have to deal with all of this, or at least you can forestall it as much as possible. Many of you know of the work that I do. Obviously, I'm an emergency physician, but even more so these days, I'm a public health professional and a preventive health specialist. And I just want to take a moment and discuss an initiative that we hope will pave the way for what medicine or healthcare will become in the future. I'm very proud in Illinois to have obtained approval by the General Assembly, which is now coming to fruition, where a separate entity called a Managed Preventive Care Organization is being put in place. The typical process by which you see your physicians and get cared for is called a managed care organization. What my team is putting together is a separate track that deals with health prevention and promotion, which means to empower you, to give you the tools to be better stewards of your own healthcare, to be educated, and to do all the things that promote health, because medical care is not health. And into the future, consistent with the Google generation, the more that you know about your health, the more that you are willing to ask questions to become knowledgeable on what's necessary, the better off you will be when the time comes to enter into the healthcare system. And as was pointed out, even then, get in the habit of developing second opinions, going to the physician with a list of questions to ask. More and more, no matter what you hear, this is going to become about you and your ability to take care of yourselves before you ever get sick, because the data is clear. Once you enter the system, if you are a person of color, you are going to suffer disparities in terms of what your healthcare outcomes are going to be. So as always, we thank you for participating in the Surgeon General Initiative. We want to thank the esteemed members of 10 Karat Gold from New Chapter Northwestern University for participating. Happy anniversary, brothers. I love you. And
Love you
we
back.
this with in 14 days, 2 weeks. Join us for the next topic in the Surgeon General Initiative. And once again, be safe and be well. God bless and good night.